Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
So, Winston, you're talking about massive hemorrhage today. How has resus changed? How has massive hemorrhage changed in the past few decades since you started medicine?
Well, that's a good question, Aebhric. In the 1990s, we had the protocol of 2 liters of saline stat, which was known as normotensive resuscitation. And then as a result of experience in Afghanistan, where we could get a wounded soldier to Camp Bastion within 60 minutes, we allowed ourselves the luxury of a period of hypotensive resuscitation, which essentially was maintaining a radial pulse. But once we found that there were delays in the transfer to ED, a concept of hybrid resuscitation was started. So we allowed ourselves an hour of hypotension, and then we had to pay back the deficit, a subject we covered in our lactate podcast some time ago. More recently, in the last 10 years or so, there's been a emphasis on hemostatic resuscitation. In other words, not just looking at establishing blood volume, but also the constituents of blood to allow hemostasis. So that's been the big change over the last 30 years.
So that means using not only just whole blood, but using the 3 different parts of the whole blood. Does that mean what you mean by hemostatic approach?
Correct.
It gives you more flexibility on how to treat the casualty. Instead of just giving them red fluid, you have 3 different things that you can tweak to address the casualty.
Correct.
So as an anesthetic doc, what are some of the cases that resulted in catastrophic hemorrhage?
Well, for the majority of us, it's trauma. But depending on which hospital you work at, depending on what specialties are a high priority. For example, in my last teaching hospital job, upper GI bleeding was very common. And then there's the cases from elective and emergency surgery, which includes cardiac, liver, orthopedics, and probably more globally, vascular surgery, and the critical one being a rupture of the abdominal aortic aneurysm. And in big obstetric units, the APHs and the PPHs can be quite difficult to manage. And obviously then in critical care, there'll always be the occasion when there's a major hemorrhage, such as reactions to non-steroidals, a subject which I'll be talking about later on in the series.
So in austere environments in LMIC countries, it's the PPH bleeding that's the major hemorrhage, isn't it?
Yes, it is. And it is interesting that it's been calculated that death from injury occurs every 3 minutes. 40% of these are due to hemorrhage or its consequences. And 60% of the deaths occur within the first 3 hours. And the hemorrhage is the leading cause of maternal death globally. However, in the West, obstetrics only accounts for 1.8%, whilst major surgery, 61%, and trauma, 15%. So the message is, it depends where you are, who you are, and what your resources are that determines the problem.
So that's interesting. And let's say that we're at KCMC and you have a postpartum hemorrhage and someone's bleeding. How do you define that catastrophic hemorrhage, or what makes a very severe hemorrhage into a major hemorrhage?
Well, I think the important thing here, rather than just talking about obstetrics, is to define what we understand by major hemorrhage. In trauma, It is loss of more than one circulating blood volume. That is 70 mils per kilogram, about 5 liters in 70 kilograms. Or loss of 50% of the estimated total blood volume within 3 hours. Or bleeding at a rate greater than 150 mils per minute. Or you could use vital signs and take a systolic blood pressure of less than 90 or a heart rate greater than 110 beats per minute, which will obviously be masked in the elderly, the pregnant, and those on beta blockade. In obstetrics, a pph of greater than 500 mils from within the genital tract within 24 hours of delivery can be stratified as minor, between 500 to 1,000, moderate, 1,000 to 2,000, and severe, greater than 2,000 mils. In upper and lower GI bleeds, there are various risk scores, but these are not really relevant to our practitioners in the pre-hospital environment.
So the treatment obviously is transfusion. So what would constitute a massive transfusion?
This is a question that nobody has really managed to give a definitive answer. It could be the assessment of the blood products used, or the shock index, which is heart rate against systolic blood pressure. But the only Delphi consensus I could find was the use of 4 units of any blood component transfused within 2 hours of injury.
Any of the three constituents, 4 units of any one of them constitute a massive transfusion.
Correct.
So what are the top 4 causes of this massive hemorrhage?
The 4 main causes are 1, trauma; 2, surgery, either elective or emergency; 3, obstetric; and 4th, medical, especially the GI bleeds and those patients who are elderly and are on anticoagulants.
So, and the upper GI is going to be like esophagus, varices, and which looks like massive hemorrhage, regardless of how much blood's coming out. That would fall under the 3rd cause of major hemorrhage.
Yeah.
So how does this work? As a paramedic, we're just taught on pushing where the red stuff is. But what is the pathophysiology underlying a major massive hemorrhage?
Well, it may come as a surprise to people that the mechanisms involved depends on the etiology. Now, we know that trauma and surgery are both similar because they both are initiated by vessel and tissue injury. So in a physiological hemostasis, the platelet fibrin clot seals and stops bleeding. However, tissue injury leads to an increase in thrombin generation, shutdown of fibrinolysis and platelet activation, increase in clot formation, and prevention of bleeding. That's the good news. In trauma coagulation, the coagulation system, I'm talking about major trauma, is unable to sustain this hemostasis. So early endogenous coagulopathy by activation of protein C, coupled with systemic coagulopathy, is important and is made worse with the lethal triad of trauma: 1, hypothermia; 2, hypoxia; and 3, acidemia. For example, hypothermia reduces coagulation enzyme activity by 10% per degree centigrade. And coupling between platelet adhesion and activation is lost between 30 to 34 degrees centigrade. Acidemia just reduces the factor complex assembly and is only 50% at a pH of 7.2, 30% at a pH of 7, and just 20% at a pH of 6.8. Another issue that occurs in trauma is the concept of dilutional coagulopathy. As you know, in trauma, there are reversal of Starling forces according to the capillary membrane, leading to a shift of interstitial fluid into the vascular compartment. This, combined with resuscitation with crystalloids and colloids, means that you have a dilution coagulopathy. And even if your resuscitation is targeted, there will also be a coagulopathy due to the presence of anticoagulants and additive solutions. So it's not an easy problem to address specifically, because we also have the hormonal and cytokine changes that lead to a complex cascade and the disruption and degradation of the endothelial glycocalyx, i.e., increased vascular permeability and the release of heparin-like substances, which worsens the coagulopathy. So that's the problem just with trauma.
Wow. And you mentioned the triangle of death, and now there's a diamond in death, and they might come out with a pentagram of pain or something. But the triangle of death, and now with hypocalcemia, the diamond of death, those are adding to the coagulopathy problem. But then you also mentioned that there's a cellular issue with a release of heparin after the bleeding gets catastrophic enough that you have a change of pathophysiology of the cells. Is that right? Did I hear that correctly?
Yeah, it's yes. There's an alternation of the coagulation system that results in fibrinolysis.
Wow. You mentioned that there's four major types of hemorrhage, and so there's going to be four different types of coagulopathy. What's so special about the trauma coagulopathy that we need to face as paramedics?
We'll discuss that when we talk about transfusion support. But I just wanted to cover points of obstetric hemorrhage and the upper and lower GI bleeds. In obstetrics, the antepartum hemorrhage is usually due to placental abruption, placenta previa, and uterine rupture. If it's postpartum, it refers to the four T's: the tone of the uterus, trauma to the genital tract, tissue retention of placental products, or thrombin. Fortunately, these are rare and difficult to predict, but interestingly, low fibrinogen is an important predictor of severity and poor outcome. True DIC is rare, and it occurs in emergencies such as amniotic fluid embolism, severe preeclampsia, or severe placental abruption. But when we move to upper GI bleeds, it's usually non-variceal, as opposed to esophageal varices, which you referred to earlier. And the non-variceal ones are due to peptic ulcers, gastritis, esophagitis, etc. And we've got to be careful of those patients on antiplatelets and NSAIDs who are usually elderly. And is one of the reasons why I'll be covering this subject in a future podcast. The mucosal abrasions lead to bleeding, and the rest is history. But the esophageal varices develop as a shunt between the portal and systemic circulation, and if there's an increase in pressure, the varices rupture, and the bleeding can be near impossible to stem. In the lower GI bleeds, it's mainly due to diverticular disease in the elderly, and the severity of the bleed depends on the size of the vessel and the size of the diverticulum. And if this persists, it reads again into a consumptive and dilutional coagulopathy. So you can see the subtle differences between hemorrhage of surgery or trauma versus obstetrics versus GI bleeds.
That's interesting, and we focus so heavily on trauma in austere environments that we do need to look at those other three. So we're looking at any one of the four massive hemorrhages. What guidelines do you follow for massive transfusion?
I would say to our general audience, follow your local major hemorrhage or institutional protocols. In the UK, the British Society of Haematology guidelines published in 2022, will be discussed now. The aim is simple: restore circulating blood volume for adequate tissue perfusion and oxygenation, maintaining and regularly monitoring hemostasis, and avoiding the lethal triad of trauma, which is hypothermia, acidemia, and coagulopathy.
And is this the same for the four major bleeding: surgery, trauma, obstetrics, and GI bleeding?
No, there are subtle differences. In general, we have a transfusion threshold of 70 grams per liter to maintain levels between 70 to 90. Use a red blood cell and FFP ratio of 2 to 1 until coagulation tests are available. Then further FFP to maintain prothrombin ratio less than 1.5 times normal. Hemostatic testing every 30 to 60 minutes, either using conventional or viscoelastic hemostatic assays, which are useful in point of care testing. Maintain fibrinogen greater than 1.5 gram per liter, and then platelet counts greater than 50 times 10 to the raised 9 per liter during active bleeding. In trauma, the ratio of a red cell to FFP should be 1 to 1. Fibrinogen supplementation if less than 2 grams, and TXA as soon as possible, and preferably within 3 hours. The first gram given over 10 minutes, followed by a gram over the next 8 hours. In obstetrics, the only difference is the fibrinogen is maintained greater than 2 grams per liter, as opposed to 1.5 grams in general. In GI bleeds, TXA is not recommended, but in surgery, TXA is recommended before skin incision in any surgery where there's likely to be major bleeding or transfusion expected.
So no TXA for GI bleeds. Why is that?
It's been found that because of the site of the bleed, the TXA doesn't seem to work as well, and in fact increases mortality in studies.
All right. So 1 to 1 for trauma, for packed red blood cells and fresh frozen plasma. Would you add platelets, or would you just stick to 1 to 1?
We'll come to that when we talk about the individual transfusion needs.
Okay.
So I'd like to start with red cells. If you've lost more than 30 to 40% of your circulating blood volume, which is about 1,500 mils in the 70 kilogram male, then you need red cells. And the target is 70 to 90 grams per liter. But you must also take into account for other fluids that you may have infused, because it takes time for the hematocrit to settle down. So use trends of vital signs, ECG, pH, lactate base deficits, etc., and transfuse through a warmer. In an emergency, group O after sampling for group and cross match, and make sure in childbearing females you use group O rhesus negative and Kell negative blood. As far as FFP is concerned, it's used for generalized coagulopathy determined by the prothrombin time, and it has both pro and anticoagulant factors together with acute phase reactants, immunoglobulin, and albumin. But the benefits include maintaining the glycocalyx integrity, that is, the permeability of the capillaries, and attenuating the endotoxin upregulation. The dose is 15 to 20 mils per kilogram, with each unit 200 to 275 mils. So the optimal RBC FFP ratios is empirically 2 to 1. But the evidence from the military is not repeatable within the civilian population, because in the former, it was very time dependent. Holko in 2015 found that there was really very little difference between plasma platelet RBC of 1 to 1 to 1 to versus 1 to 1 to 2 made very little difference. So in general, the ratio of RBC to FFP could be 1.5 to 1 in both trauma and non-trauma. We have no evidence for target figures in pre-hospital because it will depend on the longer transport times and the modes of transport that influence the various studies. Platelets, on the other hand, we know if their decrease increases mortality, even if it's within the normal range. That is to say, it's not just the numbers involved, but it's how well the platelets work. But the guideline would be 50 to the 10 to raise power of 9 per liter in major trauma, but greater than 100 in TBI or intracranial hemorrhage. What is not known is the patients on antiplatelet drugs like aspirin and clopidogrel and in GI bleeds, which worsens mortality. And then finally, fibrinogen is critical for clot formation and hemostasis, and the target levels are still to be defined. As I said to you earlier, in obstetrics, it's more than 2 grams per liter, and for other cases, 1.5 grams per liter. And we have to remember there are 2 types available in the UK. One is cryoprecipitate, which is non-purified and is a pool from 5 donors, or fibrinogen, which is better as there are reduced infection risks as it's purified. So as far as fibrinogen is concerned, we're talking about a level greater than 1.5 gram in general and trauma, and above 2 in obstetrics.
That's interesting. You mentioned platelets and aspirin or clopidogrel. If we have somebody who's been injured and bleeding, we stop the bleeding, stop the red stuff, and we know that they've taken aspirin, would you give them platelets at that point?
Yes, and I will cover this subject in a few minutes.
All right. And the other question I had, so you talked about 1 to 1 to 1 is just as good as 2 to 1, like RBC packed red blood cells compared to the fresh frozen plasma. So if you're giving a protocol of 1 to 1 to 1, wouldn't it be better to just do a buddy transfusion or do fresh whole blood?
If it's an individual case and the people involved are au fait with the techniques, the answer is yes.
Is there any difference between 1 to 1 to 1 and just a unit of whole blood?
Oh, there's a big difference because storage reduces the activities.
Okay. So talking about drugs, we've been drilled into our heads about TXA, and there's also, what pharmacological options do we have for major hemorrhage?
Well, in general, TXA is critical in major trauma, PPH, mild to moderate TBI, and in certain types of surgery like cardiac and cesarean sections. But like I said before, it needs to be given within 3 hours of injury, as survival decreases by 10% for every 15-minute delay. And PPH, same, give within 3 hours. There is very little problems with possible thromboembolic phenomenon. In GI bleeds, there is a risk of venous thrombosis, but only in high doses like 4 grams in 24 hours or delayed presentation. But it doesn't seem to increase the risks of myocardial infarction or cerebral ischemia in the general trauma models. What is not known is whether we should be giving repeat doses or perhaps even intramuscular injection, and whether, for example, in cesarean section, do obese patients need a higher dose of TXA? So there are still lots of questions to be answered.
That's interesting. It's good to know that TXA isn't going to cause an increase in myocardial infarction or stroke. So it's safe drug to give.
Yeah.
As an austere paramedic, as a medic working in some austere environment, What can we do to facilitate the management of the patient during this massive transfusion?
There are other pharmacological agents that are used in centers of excellence, like prothrombin complex concentrate, or a protein desmopressin, or DOAC antidotes, which are basically the directly acting coagulation drugs. But for the medic in the pre-hospital environment, the important things are taking a good history, and making sure that the patients are not on anticoagulants or antiplatelets, allowing individualized treatment, avoiding hypothermia and hypocalcemia, and basically following all the steps that we talked about, replacing volume, constituents of hemostasis as far as possible. But remember, doing the basics well and paying attention to detail like hypothermia, avoiding acidemia, hypocalcemia, which you referred to earlier on, is important.
So, as a paramedic, I definitely got a warm and fuzzy on getting hypothermia sorted. What can
Yeah.
I do about hypocalcemia? Would I bring that as a drug for an option?
Yes, I think the use of either calcium gluconate or chloride, is familiar to our medics when they deal with ACLS cases. So I would say point of care testing may give you a clue, and use of stored blood products would increase this possibility of hypercalcemia occurring.
So you mentioned point of care testing, and we push this quite heavily at the college with either EPOC or ISTAT, or what about or what can we do with the point of care testing? What can we do to benefit the transfusion and benefit this catastrophic hemorrhage patient?
Well, I think we're going to learn from the experiences of the last 30 years from military surgery. The convention is to do coagulation tests, and there's a not a quick turnaround of the results. What has happened in Iraq and Afghanistan is the benefits of viscoelastic hemostatic assays, things like thromboelastography or rotational thromboelastometry or sonoclot. And these can be done regularly, and the recommendations are to be done every 30 to 60 minutes. And the VHAs are more quick than conventional coagulation, but they also allow you to assess the global functional coagulation profile. But it does need expertise, and there is a lack of universal algorithms across the specialty. So I think it'll be a little more time before this becomes commonplace in the pre-hospital environment. And I don't want to minimize the extra hassle of having blood products available for you in osteo environments. But the secret as far as testing is concerned, use a repeat testing, but just remember one practical point. The viscoelastic hemostatic assays are less sensitive in detecting fibrinolysis in trauma, so do not withhold TXA.
Very valid point. Point of care testing is only as good as your trending. So trending is definitely important.
Yeah.
So Winston, we have bachelor students who are going to be writing their thesis. We have master's students who are doing their master's thesis, and their doctoral students are doing a dissertation. What are some unanswered questions in a pre-hospital major hemorrhage or massive trauma that some of our students could possibly pick up and create some new scientific evidence in this area?
That's a good question, because really the management of a major hemorrhage in the pre-hospital environment is limited by resources, expertise, and education. Moreover, the cost of a major hemorrhage is about £20,000 per patient. So in the UK, this would be equivalent to £85 million a year. Now, in the pre-hospital environment, Sperry showed that small volumes of plasma were beneficial in the pre-hospital environment, but wasn't replicated by other studies. And it seems to depend on transport times. And we really need clinical trials in the pre-hospital environment. And this is not something that an individual could do, because we're talking about a need for huge numbers, and then trying to stratify differences between the young and the elderly. What is not known is whether we should use platelets, for example, in head injuries and traumatic intracranial hemorrhages on DOACs. And the other thing which makes pre-hospital studies very difficult is that we really need to look at the long-term outcomes of those who survive, as at least one paper has suggested unfavorable neurological outcomes and poor functional status in 50% of major hemorrhage survivors. And in addition, advances in radiology, surgery, endoscopy, and ICU support will help us reassess the principles of managing major hemorrhage in different clinical situations. So, as a research subject, I would say this is such a heterogeneous population. It wouldn't be within the remit of a undergrad or even a postgrad thesis, but rather than a PhD student within an institutional backup for a PhD, provided he has the academic institution with the sufficient numbers of major hemorrhage coming through. So it's not simple.
Well, that's definitely a gauntlet to drop, Winston.
Yeah.
This has been a fantastic deep dive on massive hemorrhage, catastrophic hemorrhage, massive infusion. In any final suggestions or statements for the paramedic, nurse, doc who wants to learn more about this?
Just don't be too hasty in adopting the recommendations from studies. I've tried to sort of show the differences between massive hemorrhage management in trauma versus obstetrics versus certain kinds of surgery like cardiac and liver. So get the basics right. Think about hemostatic resuscitation. See if you can have these products available, and really follow the protocol of your institution or your employer.
That's best knowledge to follow, to follow your CPGs, your guidelines, and medical director. Thank you, Winston. And
you're welcome.
We will see you next month.
Thank you very much.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corom, Corum.org.